Experiences of how we treat patients, procedures that we do, and so it's been an absolute pleasure to be here with you, and hopefully that you'll be able to learn a few things, and hopefully it'll spark your interest in terms of wanting to do some more procedures, advanced procedures, and getting more familiar with how we can utilize implant dentistry for all of our patients. And so for this last presentation that I'm going to be sharing with you today, it's going to be a little bit more advanced in terms of grafting procedures. And so we know dentistry, especially implant dentistry, has come a long way with the different procedures available. And this one particular topic today that I'm going to share regarding bone blocks is an advanced procedure, something that takes really years of practice and years of learning. And even after you learn it, you have to keep learning. And no matter what we do, especially even for me, the learning never stops. And so that's one of the joys of being able to present, because I get to reinforce what I know and what I don't know. And I like to take these opportunities of presenting as a learning tool, so that I can go back and say, oh, you know, there's some procedures that I want to advance on, learn on, and get better at. And so this is one of those topics where it continues to evolve, continues to improve, and something that will continue to get better and better. And again, I showed you this already earlier, but we'll pass through this for the sake of time. So grafting, as Dr. Towns has shared with you, he showed you some principles and just to kind of reinforce what we do. And if I were to ask you, what is bone grafting? Bone grafting is really just the addition of bone or some bone substitute. And he went over the definitions of the different materials that we use in our practice. And so whatever material you want to use, it's really to be able to preserve or enhance that bony architecture. And so this presentation is going to really focus more on the hard tissue, the bone grafting foundation of how we can improve that foundation to be able to place implants. And so bone grafting is really just the addition of bone or some bone substitute. And the reason we graft is because we have a deficiency, right? Either to preserve or create space, to create volume, to create that foundation, to be able to place implants, to be able to stabilize dentures if patients cannot have the implants, at least something removable, but give them a firm, stable foundation. And so we want to bone graft those areas. And even today, aesthetics, in the premaxilla, aesthetics is a big reason why we may want to bone graft. Even if you can't place implants, at least if we could build the foundation to support the prosthesis, whether it's a denture, whether it's a fixed bridge, even to improve the aesthetics, we can use bone grafting procedures to help build that foundation. And we know what happens when we lose teeth. When we lose teeth, we lose bone. When we lose bone, it says, if we look at the article 27, 2007, but Homely says, an average of 40 to 60% of the original bone height and width can be expected to be lost after the tooth extraction, with the greatest loss occurring in that first year. And then Mike Sonnen published an article that says the newly dentulated jaw exhibits 10 times more resorption in the first year than those in subsequent years. So what's the critical time period? It's pretty early on, within that first year. To be more specific, it's probably going to be at the time of extraction. And so we do a lot of bone grafting procedures in our office. Because as I mentioned, we know the consequences of when we lose teeth. When we lose teeth, it's not just the tissue, the hard tissue, it's the soft tissue as well. We lose bone in the posterior maxilla, we get pneumatization of the maxillary sinuses, thereby making it more difficult to place implants. And we saw that in the clinic here as well. Patients coming in, they lost their posterior maxillary teeth. We see that the floor of the sinus pneumatized, right? We lost some bone, we got some bone resorption. Then it makes it more challenging to place implants. And that's why we have to do either a crustal approach, internal sinus lift, or an external lateral wall sinus lift. And we saw both those procedures in the clinics this week, where we did a lateral wall or a crustal approach sinus lift to be able to place implants. And that's what we see normally. So ideally, when we see bone morphology like this, we have adequate width and we have the height. It's over time when we lose those teeth that bone shrinks, and it makes it much more difficult to be able to place implants when we lose that volume of bone. Understanding that in both maxilla and mandible, we see the same pattern in the mandible where we get bone loss over time. And we have to be more concerned with the posterior mandible because of the inferior alveolar nerve. Right? That makes it more challenging, more difficult to place implants. And that's why when we look at classification systems, those classification systems aren't there just for us to memorize, but it helps us to diagnose and plan our cases. Knowing that what we're dealing with, the type of clinical scenario that we have, will help us to guide ourselves to come up with a treatment plan. So knowing whether we're dealing with a class 1, 2, 3, 4, right? Keyword and Howell Ridge form will help us to plan our cases much more efficiently. Knowing in advance, then maybe we have to bone graft. Maybe knowing in advance which approach we're going to take that case, whether crustal sinus lift or lateral wall for the posterior maxilla. So these classifications help us diagnose our cases much more efficiently. GBR classification is a very good classification system because it tells us the type of defects we're dealing with. A class 1 defect is where we have a loss of ridge width versus a class 2 defect. Class 2 defect has a deficiency in height. Now, which is more challenging to accomplish? Obviously, it's the height, the vertical component. That's very difficult. And a class 3 defect is where we have a deficiency in both width and height, making it the most difficult of all procedures to accomplish. And so when we look at schematics, this is the ideal scenario that we want to have to be able to place implants. A class 1 defect is where we have a deficiency in the width. We can still place implants, but we may be compromised. So if we have the width of bone, what's one of the ways that we can accomplish placing implants? Maybe then placing a thinner, smaller diameter implant. So we can still place implants, but maybe smaller diameter implant. With a class 2 defect, where we have a deficiency in height, it makes it more difficult to place implants, and yet we still have options of placing implants. What's one way to accomplish placing implants? Maybe place a shorter diameter implant. Right? So if you still want to place an implant, we have the width, we could place a wider diameter implant, but maybe a shorter height. It's when we get to a class 3 defect, where it's a combination of both width and height, makes it much more difficult to place implants. And so our goal is when we notice and when we see these types of defects is, I will ask myself, how do I take a class 2 defect? How do I convert this to either a class 1 or an ideal bony foundation? Then that means I have to do some type of bone augmentation, vertical augmentation to help me accomplish the goal of achieving a better foundation. If I have a ridge width deficiency, class 1 defect, my goal is how do I accomplish the goal of converting a class 1 defect to a more ideal defect to place my implants. So that helps us to plan our cases a little bit more efficiently. And so we know there's many different techniques in the market that helps us accomplish the goals of achieving bone augmentation. We can use titanium meshes, we can use tenting screws, right? We can use titanium reinforced membranes as we've seen from Dr. Towns' presentation. We can use bone blocks, right? We can use different techniques that may be split ridge, right, to maybe increase the width. So many different techniques to allow us to get to the goal of improving that bony foundation. And so for today's presentation, we're going to talk more about the bone block procedure to help us improve and increase the vertical and possibly the horizontal components of bone augmentation. Now, when we look at bone grafting, again, as Dr. Matanza showed you earlier with PRF, I do a lot of PRF. And this is that whole quote-unquote sticky bone complex where we use the patient's blood That's Professor Son. He's the one that coined that term, sticky bone. He's from Korea. Some of you may have heard of him. But he's the one that really gave the name sticky bone. And this article in 2015 really highlights the procedure, the step-by-step procedure of how do you create that sticky bone. And so that sticky bone, I like to call it babe graft because it's biologically activating bone-enhanced graft complex. Really what we're doing is we're using allograft and xenograft, combining that in a 50-50 mix combination with our platelet concentrates to help us consolidate that graft complex to give us this almost like putty-like complex. And that bone graft makes it much easier to manage, but also it also has all the growth factors and the stem cells really activating that graft complex. And so that's why I call it the babe graft. What I also like to do is I modified that original formula where it was a 50-50 mix. Now it's more of a 1/3, 1/3, 1/3 combination where I try to incorporate autogenous bone. And so I want to utilize live bone, the patient's own live bone, mixing that with the allograft and the xenograft to give me that combination, and hence I call it the babe graft, biologically activating that bone-enhanced graft complex. They're trying to upregulate the healing potential and giving it a little bit more vitality in that graft complex. And so there's the white or the yellow tube where we use the liquid portion. We want to use that to mix with the graft complex. And by mixing and combining with the graft complex, what was once just particulate graft material, now all of a sudden becomes almost like a putty. And so that's the graft complex, allograft, xenograft, mixing with the liquid portion, autogenous bone. Then what we can use, what we can see after a few minutes, it will start to consolidate and then become almost like this little putty where we can pick it up with college pliers very, very easily. Now it's easy to manage, very easy to handle. But it's also loaded with the growth factors, with the stem cells, thereby upregulating the healing. So we're using the red tube. Some of you may have seen this in the clinic. We're going to pick up that middle layer, as Dr. Towns has shown you. I leave a little bit of the red cell layer connected to the fibrin matrix, the fibrin clot. So these are the two red tubes that we've been using in the clinic. We cut off the bottom layer. That uncompressed fibrin clot, now we're going to place that into a presser. And then once it gets compressed, we can use that to create membranes. If you don't want to compress it, you can use it in whole, and you can use that in the sockets to help upregulate, to help speed up the healing process. Now the white or the yellow, we're going to use the liquid portion. The liquid portion is going to get mixed with the bone graft now. So we'll take our combination 50-50 mix. This was the original protocol where we're using xenograft and allograft. And then we use the liquid layer from the yellow or the white cap tubes. That's the liquid phase concentrated growth factors. So platelet-rich fibrin, also known as concentrated growth factors, we're going to use that complex to help speed up healing, get better healing, get better regeneration. And so that's why we use this procedure pretty routinely in our practice today. Every day we're using this procedure. And we use the liquid to mix into that combination. And then we'll take some of the serum from when we compress the fibrin matrix. We'll take some of that serum, mix it into the combination, that graft complex, to speed up the coagulation, the process of converting that into almost like a putty. And so very quickly, as soon as we mix everything up, it starts to almost turn into like this graft putty. And it becomes very, very easy to use. So we'll get some of the serum as it's being compressed. Some of the serum is being drawn into this part of the well. And that red serum will mix in, and then within a few minutes you can see how now this starts to consolidate and turn into like this almost like autologous platelet block. Some even call this a PRF block.
Có một số người sẽ gọi đây là cái khối PRF.
So we can pick it up very easily with college pliers now. Now it becomes much easier to use, to handle, but it's also loaded with the growth factors, the stem cells. And so now we have this graft complex that makes it much easier. Otherwise it gets too messy. When we graft cases without using PRF, it gets too messy, right? Bone particles, right, just everywhere. Hard to manage, hard to control. By using the patient's blood and consolidating that graft complex, it makes it much easier to use, much easier, much cleaner, and actually much more cost-effective to use. And so why do we want to use customized bone blocks? So today, we have now custom bone blocks on the market that we can use. These custom bone blocks serve an advantage over traditional bone blocks. Because when we did traditional bone blocks, we would have to go to a second surgical source, right? Whether it's the posterior mandible, the symphysis area. To harvest those blocks, it takes another surgery, right? There's much more risk involved. It increases patient morbidity, right? And it's not always 100% fit, so now we have to mold and shape that custom bone block. So we went to a second surgical site, the Ramus. You take a block, you have to trim it, you have to shape it, and you have to do that outside the patient's mouth. Make sure you have control of that graft, and it makes it very difficult to work and control that graft. So that was the past. When we take these bone blocks, shape it, it took a lot of work. Today it's much easier now when we can customize those bone blocks. So we can take a scan using the digital workflow. We heard a lot about digital workflow from Dr. Towns and from the other presenters. Digital workflow to be able to simplify even now grafting procedures. We heard about digital workflow in placement, implant placement. That works great. It works much, much more easier, much more predictable, right? Much more successful. So even with grafting procedures now, we can use digital technology to do custom bone blocks. We have more precision. It's much more accurate, much more efficient for the patients. And so when we can use some of these bone blocks, we don't have to go to a second surgical site. We don't have to go to the mandible. We don't have to go to the symphysis. And similar to what Dr. Townsend mentioned in terms of processing, it's the same process in terms of sterilization, right? You have a custom bone block for that specific patient, for that specific case. And so we can use the technology to be able to now have a completely customized bone block without having to go to a second surgical site. It's only one surgery versus two surgeries, less morbidity, less risk of failure, less risk of complications, so much more predictable to do a custom bone block. And so you can consider that as the future, but that future is the present. We want to utilize the digital technology to help us get to a better outcome. And so when we use these custom bone blocks, it's a very patient-specific for your specific patient that you're doing the case on, and it's digitally designing. Now we're using technology to design the architecture of that bone block. Right? You want to look at the scans, you want to digitally design that bone block in terms of how thick you want it, how much volume of height you're looking to achieve, so you can customize each specific bone block for that particular patient. And so that whole digital workflow is all following the same guidelines, same principles of digital workflow as we saw earlier. Restoratively driven guided surgery. So even with custom bone blocks, it's being restoratively driven. Because we want to build a bony foundation to be able to place the implants in a specific position, a specific site for the best restorative outcome. And so we're restorative driven guided surgery. And so that will allow us to have that maximum predictability. So collective intelligence means just gaining all the information, data collection to allow us to see how much hard tissue we have. Using technology, using digital technology, using CBCT to help us understand are there any anatomical limitations? Are we by the sinus? How far away from the inferior canal are we? So using that information to be able to plan our cases better. And so we will use intraoral scanning,
chúng ta
we'll
dùng
use
máy quét trong miệng.
the implant concierge to be able to
Các phần mềm để
maximize the
tối ưu hóa
workflow.
cái
So using digital
workflow này.
workflow, we take all the files, the STL files,
Tôi cần
DICOM
thu thập
files,
file
and
STL,
then
file
we allow
DICOM.
the companies to merge that
Và chúng
information
ta có
to
một
be
cái
able to
phần mềm
help
để
us
chập các
plan
file lại
and
với
be
nhau
able to
và
be more efficient.
giúp
So
đó
we'll
việc
upload the files,
sẽ dễ
implant
hơn.
concierges takes that information, they'll merge the
Tôi
data.
chập bằng
Right?
phần mềm
If you
implant
want to do that,
concierge.
you can do that, but I'd rather treat other patients. I want to see other patients, so I'll let the companies will send it out. We'll
Cái này thì bác sĩ
outsource
có
it.
thể làm được,
You
nhưng
can
mà
have
tôi
your
thì
laboratory
thường gửi cho một
technician
bên
merge the data
thứ
if
ba
they're
để
comfortable using
làm
the
giúp tôi phần
designing
mềm này, cái phần này.
software. And then we can have this
Sau đó
VIP
thì
session
tôi
where
có một cái buổi trao đổi
13 and 14, I believe, are
với lab như sau.
implants.
so that whole digital workflow, that whole VIP session, we can plan restoratively.
Thì
We
với cái
plan exactly where the
phiên
implants
họp
are
với
going
hãng
to
ấy,
go.
thì tôi có thể
Plan
lên kế
the
hoạch điều
design
trị
of the bone block, and then
lên kế
come
hoạch
up
điều
with
trị
a
cho bệnh nhân và thiết
protocol
kế được cái khối
that's
xương
going
như
to allow
nào.
us to get to that final result. So CBCT, DICOM files, we take our STL files, intraoral scans, so that we can now export that information, allow the designers to combine the
Và bên
information
họ
so
sẽ
that we can
chập,
come up with
sẽ
a whole
thiết kế một
digital
cái
workflow and a digital file
xương cho mình.
to be able to
Và
customize
thế
that bone
là
block.
cái quy trình này
So
hoàn toàn
even
được số
with the
hóa.
blocks now, because it's so patient specific, we have full control
Vậy thì với
of
cái
being
quy
able
trình
to
điều trị cá nhân hóa
maximize
như này ấy, thì
predictability.
chúng ta có thể tối
So we can use
chúng ta
this
chất lượng
information,
rất là tốt.
use the digital
Và
information,
khi mà dùng
and know that we
kỹ
can
thuật số
plan
và sử
a
dụng
large ridge augmentation
các phần
without
mềm như vậy thì
having
thấy
to
là tôi có
do
thể
a
làm một cái
secondary
ca
bone block augmentation
ghép xương
procedure.
khá là lớn
We
như
can
này.
use an allograft that's
Dùng
customized
xương
to fit
đồng
and
trục
be more
cá nhân hóa để có thể
predictable,
vừa
be
khít
less
với lại vùng
invasive.
huyết hồng.
So
Đây là
here's
một
this
ca lâm
patient,
sàng
61-year-old
bệnh nhân
male.
61 tuổi.
You can see he has a
Thế là
failing
vấn đề
dentition.
than phiền đầu tiên của họ là họ không thích cái hàm
So
răng giả
this
và
is a
răng gọi là hồi
terminal
đau.
dentition case. He doesn't like his dentures, his teeth hurt, and it's pretty obvious. You know, he's got failing teeth,
Trên
he's
đây họ có
got
một số cái răng bị mất.
a lot going on in terms of his occlusion as well, as you'll see in a moment. Denies any medical conditions, he denies any medications. He hasn't seen a dentist in 8 years, so tells us a lot. Chronic severe periodontitis, generalized bone loss with severe atrophy, and so we know that he's going to lose all of his teeth. And so the treatment plan is because of the deficiency in bone, we need to come up with a plan. We need to do the bone graft first. And so are we going to do some custom bone blocks? Are we going to do traditional bone blocks? Are we going to do GBR? You know, we're going to use tenting screws? Are we going to use titanium mesh? We felt the best solution for this patient was to, if somehow we could digitally plan our cases and then customize this bone block, that's going to give us the best result. And so that's what we're looking to do. So here's our preoperative panorama. There's your clinical photograph. Look at the occlusion on this. Deep oval bite. Severe atrophy, lung disease, right? Complete collapse of his occlusion. Right? And so CBCT just showing us severe deficiency in bone. Severe deficiency in bone. There's really no bone present.
Gần như là hiện tại không còn xương, không đủ xương nữa
Look
ở
at
tất cả vùng.
This is probably the lateral, right? There's no bone.
Ở phía nhóm trước thì hiện tại không còn
present
xương ở xương nữa.
And so even doing bone
Kể
blocks is
cả
going to
bây
be
giờ tôi có
challenging.
làm một ca ghép xương khối thì
Doing
nó thách thức.
traditional
Nếu mà tôi
GBR
làm một
is
cái
not going to be
ca
100%
với lại xương
predictable.
hướng dẫn thì lại
And so
không
we
quá
tell
dễ
the
tiên lượng.
patient, well, we
Nên
can
là
do
tôi nói bệnh nhân
traditional
là bây giờ
GBR.
tôi để làm cái pháp truyền thống cho ông.
It's not going to be
Nhưng mà
100% predictable.
khả
You
năng
may
thành công
need
nó
to
không
do
là
another
100%
secondary
và khả năng là tôi phải ghép 2 lần.
graft afterwards. But we can try
Nhưng
maybe
mà tôi có thể
doing
thử
another
phương pháp
procedure
mới.
with bone blocks.
Tôi đang làm đó là phương pháp
We can take
khối
bone
xương
from
ghép
the
cá nhân
ramus,
hóa.
bone from the symphysis.
Một phương pháp đó là
Would you
phương
like
pháp
that?
truyền thống, đó là
Or
lấy
we
xương
can
từ
try this
lấy
new
đồng trục.
technology where we can
Hoặc là một
scan
công nghệ
you
mới đó
and
là
then
tôi
digitally
thường dữ liệu từ
customize
anh
the
bằng
bone
flash
block
scan và sử dụng các
for
cái
you. So that's
và sử
probably
dụng cái
the best
khối xương
option.
ghép cá
And
nhân
that's
hóa.
the choice that
Và bệnh nhân đã chọn phương pháp thứ ba là phương pháp
agreed
ghép
to.
xương cá nhân hóa.
So here's our
Đây là
preoperative CBCT. You
mới
can
lại
see
nhìn
the
thấy là đây là
deficiency
phim trước làm ấy, thì
is
đó là một
class 3
cái phân
defect,
loại
meaning
khối
deficiency
u xương loại 3
bone
theo siêu bớt,
width and height.
mất
Right?
cả chiều ngang theo
It's
chiều
got to
rộng
combine with
và
several areas of just class 2 deficiencies.
và có một số vùng là khối u xương
But
loại
this is
2,
how we design the
đa
bone
phần là loại
block.
3. Và đây là khi mà
This is
tôi
the
thiết
bone
kế
block that we're
cái
looking to
khối
build.
xương cá nhân hóa này.
So we're going to take
Tức là
that
đấy là tôi
information.
thừa dữ liệu bệnh nhân
We
và
want to evaluate
tôi
how
muốn
much
đánh
bone
giá
we're
xem là
looking to
tôi
achieve in
cần
terms of
đạt được bao nhiêu xương.
gaining
Words
vertical
will
and
now be
horizontal.
recorded.
Đó là đang nghe cái buổi họp của tôi với lại bên lab.
So this is with the designer.
Đây là
We have a virtual
phần mềm thiết
planning
kế
session
khi
with the
mà tôi
designer,
đưa
and
tình trạng
I'm
bệnh nhân
telling
lên
her
trên
exactly
máy
where
tính
we
và
want to graft,
tôi thể
what
biết
type
được
of
rằng là
graft we're
tôi
looking
sẽ
to
ghép
achieve,
xương ở vùng
because I
nào.
want to place implants in certain sites. So we give all that information and we're trying
tất
to
cả các thông
plan
tin
and
tôi muốn truyền tải
design
cho bạn
how
như
we're
thế
going to
thì
achieve
câu hỏi đặt ra
bone
đây là
augmentation.
nó sẽ ghép mà xương theo hình
And
thức
so,
nào.
sorry, if we go back,
Đây là cái buổi trao đổi của tôi với lại
this is the setup.
đây là cái buổi
Right?
setup
There's a lot of
trước khi phẫu
setup
thuật.
that's involved, very involved.
Thì bạn thấy là
Surgical
khá là
guide
thứ cần chuẩn bị.
for implant placement, but this was a separate procedure. But the sequence of treatment for this patient was going to be, we're going to order the custom bone block.
Mua cái khối xương
Once
ghép
that's
sinh hóa này.
completed, we're going to place
Sau đó
implants in the
tôi sẽ
mandibular
đặt
arch. Right? We're
implant
going to
xương hàm dưới trước
provisionalize
và hàm dưới
that
trước
as the
và
maxillary bone graft is
lên
being
phủi
healed.
tạng.
Then we can go back
Sau đó
and
thì
place some
tôi
implants
đặt,
and then do a little bit more
implant hàm
GBR
trên và sau đó
in
tôi
localized
thực hiện,
areas.
tái tạo xương có hướng dẫn hàm
So
trên.
the first step was
Đầu
to
tiên là
place some implants in
tôi đặt
areas where I can
các implant
gain
ở
some
các vị
stability,
trí mà
because
tôi làm được.
when we
Tôi
do
đặt
the
được
custom
luôn.
bone block, my goal was to give him some type of a provisional so that we don't so we can minimize any pressure that may be
Bởi vì
applied
khi
to
mà
that
đặt
bone graft.
tôi đặt implant
Because
trên
whenever we
thì
do
có thể
a
bởi
bone
vì tôi
graft
muốn là khi mà
procedure,
làm cái khối
we have to
ghép xương lớn ấy thì tôi không muốn
minimal
là bất kỳ
pressure.
một
We
cái áp lực
want to
nào
avoid any
đè
potential
lên cái
outside external
khối
forces on the graft.
xương ghép của tôi cả.
And especially if we're doing a
Và
block graft, a
để
custom
làm
block
thế thì tôi
graft, or I'm
cầm
doing
cái phù hình
a
tạng.
ridge augmentation of premaxilla, we want to try and avoid any unnecessary forces. So the goal was to place some implants in the posterior areas
Đấy là lý do
somehow
mà tôi đặt
so that I can at
tôi cố
least
tình đặt
utilize some type
implant
of
vào phía nhóm
removable
đằng sau.
denture without any flange
Tôi không muốn
in
là
the
bệnh nhân
area
sẽ
that
bị đeo
we're
một cái
grafting.
răng giả.
So that was the initial goal. So while that's being done, we had already placed some implants in the mandibular arch.
Thế là tôi đặt được 8
And so we're going ahead. This is how we present it. So the mandibular arch was
Ở dưới
provisionalized.
đã được đeo phù hình tạng.
But the maxillary arch, look at the occlusion, complete overbite. Right? So we know in the future that we're going to have to raise his vertical, right? Recreate his vertical dimension. But the goal was to somehow get some implants placed so that we can somehow establish a vertical. And then knowing that the mandibular arch, we have a fixed provisional that's going to help give him a little bit of stability. So we plan now for the maxillary arch. So here's that custom bone block that was fabricated. You can see I have implants placed posteriorly to somehow be able to utilize with some locators as using the maxillary denture as the provisional. This is the custom bone block that was created. Very, very detailed in terms of the size that's going to be custom fit for that particular patient. And so this is an allograft that's going to be used. And then this is the surgery. So look at a large defect there. Large bony defect, no bone whatsoever. So I'm trying to use, that's why we wanted to use a couple of implants to be able to support a provisional during healing. So the size and dimensions of that custom bone block. So you can see, I just took that bone block and just fit it right over the defect. And it actually fits very, very snug. Very, very nicely fit over that defect. Because it was digitally designed to custom fit right over that bone. And then we need to secure it, so we're going to take some fixation screws. But we didn't have to do any modifications to that bone block whatsoever. When we go to a second surgical site, we do a custom bone block, you have to trim it so that you can have an intimate fit over the bone. This case, because it was so accurate, all we needed to do is fit it over the defect. And then we're using fixation screws to get fixation. So we're going to use these long screws fixated to get complete immobility of that graft. You have to have complete immobility. It has to be very, very stable. The defect that you see here, he had teeth here. So we had originally planned to use teeth, but he lost that before we were able to do the procedure. That's why we see a defect here. So we said we could go ahead and continue with the graft, and we're going to just use allograft to graft that defect there. So the second screw is inserted, and then here's the third fixation screw. But you can even see there's no mobility of the graft, even with just two screws that were fixated. So long screws that's going to secure and stabilize that allograft, that bone block, to the patient's host alveolar bone. So this is the sticky bone, the babe graft. Now we're going to use that graft to fill in voids, and we're going to graft all around. We're going to use more bone graft material to graft all around. So that defect where the tooth was, we're going to just use our sticky bone, what I call the babe graft. It's an allograft, xenograft, autogenous bone complex. But just look how easy it is to handle. It doesn't migrate. When blood or saliva gets in there, you don't lose a lot of the material. It's all consolidated into that graft complex. Just so much easier to use and manipulate. So it makes it much more efficient, thereby allowing you to perform your surgery much more efficiently, much cleaner. And so we're going to graft on the facial, we're going to graft on the buccal, we'll graft on the palatal. But you need at least those 3 screws to fixate and stabilize that graft. There has to be low mobility within that graft. And you saw the porous nature of that graft, where it's going to allow the blood cells to flow through. Right? We talked about having good blood supply, vascularity. That's going to be key to the success of the graft, to making sure that we can have a good blood supply. And so for this patient, we have pretty good blood supply. Now mind you, when you do these procedures, you have to have good primary closure of the flaps. That's going to be the challenging part, to make sure you get good primary closure. And so I want to graft more than I need. I want to have an overbuild of the foundation, so that way it can count for some resorption over time. Because I know we're going to get some shrinkage over time. So you graft more than you need. So we're going to graft inside, we'll graft outside on the outer surface of where that custom bone block is. And that's why we want to make sure that we provisionalize, that we're going to minimize and avoid any type of pressure onto the grafted site. So we're just adding more part. This is probably more xenograft now that we're using. But you could already see the volume of bone that's being used, and how much bone that we're being used. So I want to try and avoid, I want to try and fill in all the voids around that custom bone block. I want to try and have a smooth transition from the distal ends of the bone block. So that's why we use a particular graft to blend that in. And that's one of the benefits of using PRF. Platelet-rich fiber is going to allow the body, allow the patient to heal faster, right, to heal more predictably, nourishing and giving it more growth factors, more stem cells. So this is all now more just xenograft. And I'm layering xenograft because the further away from the defect I go, I'm trying to utilize material that I think is going to last longer. Right, so we know xenograft is not going to really turn over, it's not going to go away. So we use the xenograft over the graft complex. And the xenograft, you can see it wasn't consolidated with the sticky bone, so you can see how messy it started to get when it's not consolidated. So we're trying to do now a very aggressive periosteal release. You have to be very aggressive to get primary closure, making sure you get good primary closure. So you have to be very, very aggressive with that release. And so that's what we're looking to do. And we tell the patients when we do this, you're going to get a lot of swelling, you're going to bruise, get black and blues up to the eyes and even the neck. Right? We want to give them the worst case scenario. So trying to see that we get complete primary closure. That flap has to be very, very passive. So sometimes I'll go through multiple blades. I'll use 2, 3 new blades because the only way you can get good periosteal release is making sure you get good sharp dissection. So you have to use very sharp blades. And as you do that, you can see you're going to be inducing more bleeding. And as we get more bleeding, the loose particulate graft that wasn't consolidated with the PRF, you can see how it's starting to get washed away. You're losing some of the graft material. But the ideal way to get primary release is you have to pull on that flap and then make your incision to try and reduce some of that tension along that flap. And so you can see, I'm testing and seeing if I'm getting primary release. That's why you have to use new sharp blades and making sure that
nhìn vào
dissection
đường rạch của tôi
is
bạn
a
thấy là
clean
vì sao mà tôi
dissection
cần
to try and
lưỡi
minimize
dao mới để tôi có những cái đường rạch
all the trauma.
nó rất là ít sang chấn và nó rất là sắc.
So this is not an easy procedure
Và
to
đây
do.
thì không phải là một quy trình
And
dễ.
especially when we have all this volume
Đặc
of
biệt là khi mà bạn
materials
nhìn vào cái lượng
underneath.
xương tôi cần tăng lên.
And as we relax the lip, you can see the tissue starting to come over, giving us a sign of
Đó, thế là
getting close to having good
khi
primary
mà
release of that flap.
cái vạt phía ngoài nó đã
Now
hơi
we
đi
have to
lên
cover
phía mặt
this
nhai, tức là tôi đã gần
block.
đủ để đóng mặt
Traditional
rồi.
protocols will tell you that when you do block grafting, especially if you're doing autologous block, you don't need to use
Thì
membranes.
bạn không cần dùng màng.
But I like to use barrier membranes just to make sure that I can have more protection over the
Tôi có một cái
graft.
sự bảo vệ
So
đủ
this
tốt
is a
đến
collagen
khối của
membrane that
tôi.
we're going to use.
Trong ca này
And
tôi
we'll
dùng màng
use a
collagen.
combination of collagen membranes and PRF
Khi
membranes
mà chúng ta dùng
over the
màng
graft.
collagen và thường thì tôi
So
dùng
here's the
màng
collagen
collagen
membrane. So it's a large graft. So we're using a large membrane. We want to make sure we tuck it in underneath the flaps. Make sure you can tuck it in underneath the palatal flap.
và trong.
And so having that release, making sure that it's covering the graft
Cần
complex.
đảm bảo là cái màng collagen này nó che phủ được khối ghép.
So you can see I'm trying to making sure that I can tuck it under the flap. So I'm trying to release even the tissue on the
dưới
palatal
vạt
side.
phía khẩu cái.
And the hardest part, the challenge, look at it, we're trying to get good primary closure.
Tình huống cuối cùng là tôi cần đạt được cái đóng vạt thịt.
That's going to be the challenge, making sure you get primary
Bước
closure.
khó nhất của cái cam ớt này.
And then making sure that it stays closed during the healing period.
Cái vạt nó luôn được đóng ở trong
So we use
cái thịt lành thương.
collagen membranes, and we're also going to use PRF membranes. PRF, we know PRF is going to be is going to be advantageous and beneficial for soft tissue healing. So that's why in this case I used the collagen membrane first, and then I laid the PRF over the collagen membrane, because I want to make sure that if I get a little bit of soft tissue breakdown, then at least the PRF as it's closest to the outer surface is going to hopefully induce a little faster soft tissue healing. So multiple layers, we're using multiple layers of the PRF, laying it across the facial, towards the palatal, tucking it in.
Collagen và tôi nhét vào phía mặt lưỡi và phía mặt ngoài.
And again, as we add the collagen membrane and as we add the PRF membrane, again, that's volume of material that we're adding. Right? So there's a lot of materials that we're introducing into this graft. Again, just testing to see that I can get primary closure.
Xem là màng tôi đã giảm căng đủ chưa, cái vạt ngoài tôi đã giảm căng đủ chưa.
Right? Making sure there's not going to be tension on that flap. That's what we're testing.
Rằng là cái vạt nó không căng.
And then we're going to introduce multiple suturing techniques.
Tôi sẽ giới thiệu với các bạn khá nhiều kỹ thuật khâu trong cái ca này.
The initial deep horizontal mattress sutures is going to help stabilize the membranes, and then we'll use vertical sutures. Then we'll use interrupted sutures as well.
Cái đường khâu chéo trong cái ca này, cái mũi điện ngang đầu tiên được gọi là mũi điện ngang sâu để cố định cái màng collagen.
So, but the key to the success of this case is making sure that we can maintain that primary closure. Because if we lose that primary closure, then there's a good potential of that graft not succeeding.
Cái ca ghép xương này sẽ không thành công.
Okay, so once we get to some suturing, I can advance to the next one. So as you can see how we have almost tension free. The tissue is just kind of laying over the graft.
Tôi đã đóng vạt được cái vạt tôi đã giảm căng
making sure that it's all tension free.
Như hình như trên
Okay, here we
video
start
này,
our
tôi bắt đầu
deep
khâu.
periosteal sutures now.
Tôi bắt đầu khâu một cái mũi
So
đệm.
going deep now into the periosteum.
Mũi khâu màng xương sâu.
Because I want to use these sutures to stabilize the membrane
cố định cái màng.
over the multiple layers of the membrane bone graft. So it's a continuous deep periosteal mattress sutures that we're doing. So that's going to be the initial suture.
Là mũi khâu đầu tiên của tôi.
That's going to bring everything together, holding down the membranes.
Sẽ làm cho cái nó sẽ
And then we can
mũi khâu này nó
introduce
tạo ra áp lực để nó ấn cái màng
interrupted
ấn
sutures,
cái
and we
màng
can
collagen xuống.
introduce continuous sutures on the outside.
Đây là cái mũi khâu bên ngoài.
Đây là một cái mũi điện ngang liên tục mà tôi sẽ châm từ mặt trong.
Okay, so
và sẽ không
I'll
vào
move
màng
on for the
xương,
sake
sau
of
đó đi
time.
ra mặt.
So here's the
Sau đó là
severe
tiếp vào
bone
mặt trong và đó
defect. Look at the
tiếp tục để cố định cái
thinness of
màng.
that bone
Thì đây là
that
cái
we're dealing with.
dạng xương ban đầu.
And so it makes it very difficult in terms of how you're going to be able to place implants. You can't place implants in this. So you can only do bone grafts. Look at the anterior nasal spine. Look at that large defect. So that custom bone block is going to fit right over that defect.
Và chúng ta có thể là đặt cái phần xương khối ngay ở bên
So
trên.
we create we prepare our sites. I didn't have the picture, I apologize, but you have to decorticate the bone, right? So decorticate the host bone. We could fit the custom bone block. We had some teeth here. That's where the voids you saw where we were grafting, but this fit right over that defect. And it fit exactly how we planned it digitally. And then the 3 fixation screws. And I like the porous nature because it allows the blood cells to flow through the porous bone block. And then we start adding our graft, our babe graft, our sticky bone, and then here's the collagen membrane. There's the multiple layers of our PRF, and then here's our deep periosteal sutures that's going to stabilize the membrane over the graft. And then get a good primary closure. And we're using multiple different types of sutures. I like using polypropylene sutures. We have resorbable PGA sutures, but that graft has to stay closed. 1 week healing. Look at the volume. Right, a lot of volume in there. A lot of volume. That's the bruising that I'm telling the patient about. He's going to bruise. Right? And they get surprised because they say, why am I bruising down my neck? Right, that's part of healing. So a lot of bruising. Post-operative CBCT. This is all grafted bone. This is all grafted bone. That's from the custom bone block. You can see the long fixation screws, right? Securing the stability of that graft. And then I'm using those 2 implants to support an overdenture for the provisional and cutting away that buccal flange. And so custom bone blocks will allow us to go a long way. But look what's happening 3 weeks out. 3 weeks out, my flap is starting to break down. Right? So when I see this, it worries me. Because if it breaks down anymore, I'm going to lose that graft. We're going to get resorption. So it makes me very, very worried. So what do? I went in and I undermined my flap a little bit more. Undermine my flap and I just used PRF. Just PRF. So placed a couple of layers of PRF and then resuture. I didn't want to advance the flap completely, but I'm going to allow the PRF to introduce the growth factors, the stem cells, to give me some soft tissue healing. And then 2 weeks post-op, you got some pretty good healing. There's the provisional denture, which we relined at this point with a very soft reline 5 weeks post-op. And she's now is looking much better than when he initially came in. But we continue to monitor, we follow through in terms of healing. The soft tissue is doing much better. But still, the incision line, that's the scar from that initial surgery. And then this is the panoramic, the pre-op and the post-op. You can see the fixation screws. Now we're ready for implant surgery. We expose the graft. So this is now an uncovering, exposing the graft. We're going to remove those fixation screws. You can't tell from the photo, but we got some decent volume of bone. We had lost a little bit from that initial, you can see, we lost some volume of bone. And that's probably that's definitely because of the provisional. So you have to make sure that we remove the flange completely. That's the before, there's the screws after, right? Losing some volume, and then we're able to place implants, but then I go ahead and graft more now. So we can do our implant surgery, I can get implants in now. I know that I can graft more now. And then I'm able to now transition to a fixed provisional. So take the patient from the denture to giving him a little bit more fixed support.
và
And then we
hàm
can
răng
take
chúng
him
ta đã
now
được cố định
and then
nhiều hơn.
transition him
Bằng
to
cái
implants with a
chúng ta
fixed
chuyển đổi sang
provisional.
hàm cố định trên
Now we
vai.
can work through the prosthetics. So the initial pre-op,
Đây là hình ảnh trước bộ phận.
post-op, taking
Sau
him
bộ
from
phận.
what was complete collapse and deficiency of
Và
bone
chúng ta
to
đã
giving him
xử
something
lý
a
được
little
cái
bit more
phần xương bị
stable.
hỏng và có
And then
được
able to
một
place the
dạng
implants and then
phục hình ổn định.
finalize his
Lên.
prosthesis.
Và đây là kết quả
And
sau.
so that case kind of worked out pretty nicely. So he was pretty happy that he didn't have to wear his dentures
Nhiều bệnh
anymore.
nhân rất là hài lòng với cái kết quả như
So
vậy.
we'll complete this presentation with one more case. This is a vertical deficiency in the posterior mandible. So those cases are very, very challenging. So this is going to be more of an onlay graft. And we know when we do vertical, that's the most difficult, most challenging cases. Almost clinically knife edge ridge. This is the patient's CBCT. Very close to the inferior alveolar nerve. That's why we're planning to do a vertical augmentation, because too close, not enough bone to be able to place implants. But the patient, she could not tolerate dentures. And so she said, you can do, please, anything to help not wear dentures, to get any type of implant in, so that at least she could basically function a little bit more efficiently, function a little better. Pre-op CBCT, class 3 defect, again, using the same protocol, digital workflow. We're going to do the same process in terms of planning and building our case to customize the bone block. We're going to use that information, send it over to the laboratory, to the technician, and that's the custom bone block that's going to fit right over that knife edge ridge. So that's the custom bone block. You can see how accurate it's going to fit, because it's custom made to that particular defect. So use this custom bone block. Again, the porous nature of the graft is going to allow all the blood cells to flow through, because that's what's going to nourish the graft. Mind you, this is a dead bone, right? So we want to use this graft, right, to somehow build up vertically and to be able to place implants. So customize the same protocol using platinum-rich fibrin, doing PRF, using collagen membranes, same protocol. And anytime we do grafting, we're going to also use the patient's PRF. We're going to use the serum portion, the liquid portion. We're going to hydrate that bone block. Instead of hydrating saline, we're hydrating in the patient's own growth factors, the serum with the stem cells. So now we do our full thickness flap, expose the bone, that's the alveolar ridge, decorticate the bone to create bleeding. Custom fit. I mean, this case went so smooth. I took that bone block, opened the flap, I placed it on the ridge, and it fit like a glove. It just sat right over that alveolar ridge. And then it just becomes very, very easy. Again, fixation screws to stabilize the graft. And then we use, again, periosteal release, PRF membranes, collagen membranes, to get primary closure. You have to get good primary closure. So here's the medial posterior. You can see the deficiency. That's the bone block. The inferior alveolar canal is down here, mental foramen. Mental foramen, you can see fixation. The outline of the block is up here. Making sure we get good fixation. And immediate post-surgery. 3 months post-surgery, it's starting to get more dense. If you look at the panoramic, the radiograph, compare this at the day of surgery to the density of the bone 3 months later. A little bit more dense now as it's getting nourished, as it's healing. So that's a good sign for us. If it wasn't getting the blood supply, sometimes you'll see a deficiency, bone loss, depression. But it's starting to get more dense over time. 3 months post-surgery. This is a common occurrence that we see, not even just with titanium screws, with titanium mesh. Sometimes it starts to self-expose. That's one of the complications. In this case with the screws, look at the tissue though. The tissue around the screw is very healthy. It's not inflamed. And so we'll tell the patient if it starts to get exposed, just to make sure to keep it clean. We don't want to introduce any plaque or bacteria. So as long as they maintain it, keep it clean, it remains pretty healthy in terms of soft tissue. So we let that heal, and then once we're ready for the implant placement, we can go ahead and perform our implant procedure. So 3 months post-op surgery, we wait, we let it heal, we continue. That was the pre-op, now we're ready for implant surgery. Right? This is 5 months post-surgery. So custom bone block, you can see the screw getting exposed, and then we're ready for implant surgery. We expose it, 5 months healing now. This is 5 months post-healing, and it's still there once we expose it. Here we go. There's the bone. We remove the screws now. We can remove the fixation screws and place our implants. So 3 implants placed in that custom bone block, and then let that heal. And what I like to do is I'll add more bone when I place implants. I want to protect it and add a little bit more bone. So we do a lot of bone grafting procedures just to make sure to give me a little bit more insurance and 3 implant fixtures placed. So the patient actually was undergoing some other medical condition, so it hasn't been restored yet. We actually just temporized her about a month ago, so she's in a provisional and then just dealing with some of her other medical conditions. So why custom bone blocks? Because it's very patient specific. If it's very patient specific, we have more precision in terms of the grafting procedure. And it makes it much more simpler. You don't have to go to a second surgical site. So it minimizes morbidity, minimizes complication, minimizes the potential for failure. So it gives us this simplicity, saves time, because we don't have to go to a second surgical site. And when we're doing these procedures, you can see just the time involved is much, much less, as opposed to if I had to do a custom bone, a second bone block. Customizing the fit, trimming, shaping it, so that time is so valuable because it's going to introduce less trauma to the patient, much more predictable for the patient. And so, with that, I'd like to say thank you, and this is something that's been new on the horizon that's going to continue to evolve. And if you're interested in learning more about this, you can always reach out, and then we can give you some more guidance in terms of how to be more predictable with grafting procedures. But thank you so much for being here. Thank you for allowing me to share my experiences. It's been a pleasure, and I hope to be back again soon.
Thank you.